Thank you. I have the unenviable position of standing between you and lunch, so I will not take 30 minutes, but I will tell you about, first I'm going to learn how to advance the slide, and then tell you about surgery, abdominal surgery primarily as it relates to kids with MSMDS. There are many GI complications associated with the condition. These will summarize it a little bit better. So first, feeding difficulties are quite common. These percentages are based some on internal data from MGH, from Mass General, as well as some published data, but roughly 50% of children will have some challenges with weight gain or feeding difficulty. Intestinal malrotation is a significant issue. We're going to go through each of these, well, not in all of them, but gastroesophageal reflux, so heartburn, a very common problem. Intestinal pseudoobstruction, where the intestinal motility is just not normal, is common, as well as is the need to have the gallbladder removed. And finally, chronic constipation is a pervasive problem, which you'll learn more about when Dr. Rahman speaks after lunch on the effect of ACTA2 mutations on colonic function. So when it comes to intestinal malrotation, this is one of the most serious problems that can happen in a newborn. It's the sort of most well-known surgical emergency in neonates. The intestine has this process of turning and twisting in just the right way during development, so that when a baby is born, is there a pointer? No.
Red one.
Red one. Thanks. The position of the intestine, which when you open the abdomen, it looks like there's just intestine everywhere, but it's actually organized very deliberately so that the beginning of the small intestine, this is stomach and the duodenum, and then this part of the small intestine and all the rest of the small intestine is spread out in the abdomen from the left upper abdomen to the right lower abdomen. The appendix, and then the colon is wrapped around the outside. When that rotation doesn't happen normally, kids have the risk of twisting their intestine. So if it doesn't get oriented properly, where the small intestine goes from up here to way down here, and the beginning of the small intestine right here and the end of the small intestine are really close to each other, we call that intestinal malrotation. And what can happen is that the intestine can twist. And so this phenomenon of twisting is called midgut volvulus. I don't know why kids with an ACTA2 mutation are at risk for intestinal malrotation, but it's a well-known problem. It needs to be identified early, because when the intestine twists, it can cause the blood supply to the intestine to get just sort of twisted off, and blood can't drain out of the intestine or get to the intestine. There's a risk of the entire small intestine dying, which is truly a very serious problem. So usually it presents in infants, and they have this vomiting bile. But it can present later in life, because if you have malrotation, intestinal malrotation, you can twist your intestine at any point in your life. And we've studied at Mass General, and we find that actually only about half the kids present before they're 1 year of age. And then we've had 80-year-olds, people in the 50s, 60s present with midgut volvulus, the twisting. Those patients present, it takes a long time to figure it out, because adult providers don't really think about the diagnosis. They often present with abdominal pain, nausea, and diarrhea. Often, and it's interesting because when you twist the intestine, one of the things you twist is the lymphatics, which you heard about, and the lymphatics can't drain out of the intestine. Lymphatics are very important for absorbing fat, so they get this fatty diarrhea. The reason to know all this is just to be aware of the symptoms. If there's unexplained vomiting of bile and there's known malrotation, when the intestine is just not positioned properly, we have to consider the possibility of midgut volvulus. And the operation is very straightforward for how to correct midgut volvulus. You have to just untwist the intestine, divide the abnormal attachments, and put the position of the bowel in a way that the beginning of the small bowel is as far away from the end of the small bowel as possible. And that broad base reduces the risk of it twisting again. The most common operation we probably do in kids with MSMDS is placement of a feeding tube. And there are many reasons. In pediatric surgery, we do a lot of feeding tubes in kids. Sometimes a kid just needs a feeding tube for a short period of time, a few months. And in those cases, you can put a nasogastric tube or a nasojejunal tube, depending on whether you want to feed the stomach or the small intestine, and we'll talk about why you do one or the other. A feeding tube shouldn't stay in for more than a few months because of the risks of sinusitis, erosion of the nasal septum, the need to put it in and out, the discomfort associated. So then there are options for when you need a feeding tube for a much longer period. And the most common is a G tube, and gastrostomy tubes. Almost everybody at this point uses these mini one or Mickey buttons. They have a little balloon at the end, and that's what keeps the device in the stomach. And they're low profile, so very comfortable on the abdominal wall. Feeding the stomach is the best way to feed the GI tract in a patient who can't eat by mouth, because it's physiologic. It's the way you're supposed to eat. You can get a bolus feed. The stomach is very important when it receives nutrients. It activates secretions from the bile, from the gallbladder, from the pancreas to help with absorption. But you can't do it if the stomach doesn't work, if it doesn't empty well in gastroparesis, if there's terrible reflux and food just goes in and straight up the esophagus. And in those cases, there are things we can do to still allow feeding the stomach, but we have to combine it with additional surgery, like a fundoplication, an operation to prevent reflux. In kids who can't tolerate G-tube feedings for whatever reason, there's really two other options. And one is a GJ tube. So through the same G-tube, the stomach, we just put a tube that's much longer, and it goes through the stomach into the duodenum and into the jejunum, the second part of the small intestine. These are very effective at feeding kids with stomach issues, like I said, like reflux or gastroparesis. It's easy to place endoscopically, radiologists place it, gastroenterologists place it, and you can actually empty the stomach while you feed the jejunum. There's two ports on these tubes. The problem is you have to feed the small intestine continuously. It's just a little tube, so you can't just pour in a bolus feed. You have to be attached to a pump all the time, which is sort of unpleasant and limits activity. The other problem is that this long tube, easy to clog up with either intestinal secretions or food formula. And the other problem is it's sitting here, the tip, and it often flips up into the stomach. Last week we had one flip up into the esophagus, and they need to get repositioned on average every month. So my preference, if someone can't tolerate G-tube feeds, is to place a J-tube. A J-tube, we use the same button as we do in the stomach. If he's interested, there's a way to do it through a very small incision, and put the button directly into the small intestine. That's the balloon right there. And like I said, these disadvantage is that you can't bolus feed still. It requires continuous feeds, but it's secure. It's not going to flip anywhere. There's no long tube to get clogged. And there's some risks in how, depending on how you do it, there are some potential complications. The volvulus, or the intestine can twist around this loop of intestine that's up there. But anyway, I think this is a very effective way in kids who just can't eat by mouth, can't tolerate feeding into the stomach. A tube into the jejunum works well. There's a long discussion we could have about, well, do you get a J tube or do you do a G tube with a fundoplication? These are very sort of like common conversations in pediatric surgery, and it's hard to give you any generalization. It's entirely dependent on each patient and also on what the family's goals are for feeding the kid. Constipation we see a lot in actin 2 mutations. Alpha-actin obviously is expressed and very important in vascular smooth muscle, but it's also expressed in the intestinal smooth muscle, which is why it has all these consequences in the function of the stomach, small intestine, and large intestine. In the large intestine, we've seen many kids who have constipation need laxatives or enemas to be able to evacuate. There are some kids, though, the constipation is so bad that it does not respond to those kinds of medical therapies. And believe it or not, there's surgical ways to treat constipation. We limit that to the most severe cases where no medication is effective. These kids will often have abdominal pain and bloating, what we call encopresis, which is just overflow of stool that's just sitting there, can't get out, so it leaks out over the course of the day. That is a terrible issue for quality of life of kids. We've got kids who are not allowed to go to school because they smell or they have leakage. And so the impact on their emotional development is significant. In order to figure out the right treatment, we have to figure out the cause of the constipation, and there is a long list of issues. Having a bowel movement seems like the easiest thing in the world if you can do it, but it's actually remarkably complicated how stool comes out. And so there are issues with colonic motility. There's the rectum has a lot of sensory and motor function, the anal sphincters, the pelvic muscles, so the pelvic floor, and all these things. We have ways to study them and try to figure out where is the problem so that we tailor the appropriate treatment. So there are a few different ways that you can treat severe constipation in kids like those with MSMDS. We'll talk about each of these. One very effective thing you can do is called an ACE. I don't know if anybody here has a kid with one, but these are enemas that instead of going in the rectum, it's a retrograde enema, they're antegrade enemas. They go directly into the large intestine. This is the cecum, which is the first part of the large intestine. They have the right colon, transverse colon, left colon. And so we can put bring up the appendix. Here's the appendix. You open the end of it, you sew it to the belly button, and right there, that gives you access into the large intestine. And every day, just flush the colon with a solution, usually like basically Miralax. The procedure I prefer is, again, relies on that same balloon button, the Mickey or Minnie. There's another button called the Chait button, specifically designed for this, where we just put it directly into the cecum. And then every day, it's the same as this. You just sit on the toilet, deliver anywhere from a few hundred to up to a liter of fluid, of enema fluid, right into the colon and flush out the colon every day. The way this works is it accomplishes these goals. If you have severe constipation or fecal incontinence, either one gets treated by this because it cleans the colon. It's just plumbing. It just flushes out the colon and keeps it clean until the next day when we do the next one. Kids usually sit on the toilet for 30 to 45 minutes. They learn how to do it themselves. And it's a significant improvement in quality of life. It's very effective in kids with like spina bifida who are wheelchair bound, where having bowel movements and cleaning is a real challenge, and it really changes their life and their families' lives. And so we reserve it for kids with in the case of MSMDS, we're talking more about severe constipation, only if you really fail all other medical approaches. And the success rate is about 85%, success being the ability to flush yourself and stay clean and comfortable, no pain, no bloating for the rest of the day. Another thing, these are now we're getting to the more severe cases of constipation. Every now and then, we just have to make an ostomy and put a bag on. Here's an example of a kid. The colon should not be, this is an enema, barium enema. The colon here is just massively dilated. That happens when, for example, if the smooth muscle really doesn't work to contract and move things along the colon, it'll just stretch like a bag. And there are times when it's so stretched out, it has absolutely no function. We call that colonic inertia. We do colonic motility testing to diagnose that. In these cases, if you were to do the antegrade enema, you're just going to pour fluid into a bag and it'll just get more stretched out and have nowhere to go. So we just divert the kid, make an ileostomy. Interestingly, in many of these cases, after about 2 years usually, this will shrink down in size. And then when it's smaller caliber again, now the contractions are effective, because if it's this big, the contractions do nothing. And when it's back to normal size, it can work. This is an example of that, where it was just a huge colon before the ileostomy. And then he had the ileostomy, and a year and a half later, you can see it's just back to a normal caliber. And then we can close the ileostomy so they're not forever most of the time. And then normal laxatives and high doses, but laxatives can then control the bowel movements. Sometimes we have to take out a piece of intestine, a piece of the colon, the whole colon. Again, it's all guided by a careful understanding of where is the problem. Sometimes you can say, oh, it's the left colon that's the problem, or it's the right colon. But if the problem's the anal sphincter or the pelvic floor, the muscles that control continence, you can take out all the colon you want, but we can't take out the pelvic floor. And so we would be back at square one and have a worse problem. So it's important to be very careful in patient selection to make sure you're doing the right thing for the right patient. Chronic intestinal pseudoobstruction is something that we see more often in kids with ACTG2 mutations, gamma-actin. That's another actin that's much more involved in gut motility. We also see it in kids with ACTA2 mutations. So pseudoobstruction means that the bowel looks what? It looks like it's obstructed. It's hugely dilated, full of air. There's these things called air fluid levels. Things are just not moving through, but it's a pseudo-obstruction. There's no actual blockage. You can get this if you have scar tissue from previous surgery, or a tumor in the intestine, or a twist. But in these kids, there's no blockage. The gut just doesn't work. It can affect the stomach, the small intestine, the colon. Most of the time, it presents very early in life, 80% by the time they're 1 year old. And it is pretty rare. It's estimated that only about 100 babies are born each year with pseudo-obstruction. And you can see on these CAT scans, this bowel is hugely dilated and full of air. All the black is air. It's very uncomfortable. Chronic nausea, vomiting, inability to pass stool. Obviously, it's hard to eat when you're like this or to be fed, so they lose weight. And it's also the smooth muscle of the intestine, very similar to smooth muscle of the bladder. So ACTA2 mutations also affect the bladder. You can get a very distended bladder that doesn't empty well. The ones we're interested in the case of MSMDS are called primary chronic intestinal pseudoobstruction, ACTA2 and ACTG2 mutations. Also that MYH11, which is the one everybody's talking about with the mouse model. MYH11 is a myosin heavy chain gene, so also expressed in the smooth muscle. Filament A is a gene or a protein that's expressed in the cytoskeleton. It creates the structure, regulates the structure of the smooth muscle cell as well as the neurons. And so it causes both a myopathy or a neuropathy. There's two major ways to screw up your intestinal motility. One is to have a problem with the smooth muscle, and the other is to have a problem with the enteric neurons, the nerve cells that control the smooth muscle. There are many other reasons people have chronic intestinal pseudoobstruction. We can, and with lunch, I love talking about these things though, over a big sandwich, so pleasure. And the treatment for these is, you can enteral nutrition, so a feeding tube, so you can give slow, continuous feeds. If they can eat by mouth, small meals, because too much, they can't move it along. It just creates worse bloating and pain. There's some medications that help the intestine to move. These are actually interesting medicines. They're used in myasthenia gravis. They inhibit acetylcholinesterase, so they inhibit the breakdown of acetylcholine. Acetylcholine, which controls cholinergic activity, is the neurotransmitter in the gut that we call excitatory. It causes the intestine to squeeze. So the more acetylcholine, the more squeezing of the intestine, and that seems to help some of these kids. And then there's obviously some of the worst cases. They need a feeding tube often. Sometimes they need the bag, an ileostomy. And really when the disease is progressive. So we see kids when they're young, they're just eating a little slower. And then all of a sudden they need a feeding tube. And then they're teenagers and they're in the hospital repeatedly. And then eventually many need a bowel transplantation. The last thing I just mentioned is the anesthesia issue. So for us, doing the surgery is pretty straightforward, but we all get a little nervous with the ACTA2 patients because of the risk of general anesthesia. So the main concern in MSMDS is fluctuations in blood pressure during general anesthesia. Everybody gets hypotensive under anesthesia. The blood pressure goes down. If you look at a plot of blood pressure, which is available for all operations done, it always goes down. That's because anesthesia blocks the nervous system, basically. And by blocking the sympathetic nervous system, it reduces the tone of the smooth muscle and the arteries and the veins, and that makes the blood pressure drop. Most people can then auto-regulate the blood pressure in their brain by contracting the vessels in the brain. When we contract the vessels, because the smooth muscle works. If your smooth muscle in the brain vessels doesn't work well, like if there's an ACTA2 mutation, then the low blood pressure affects perfusion to the brain and hence the risk of stroke with general anesthesia. So whenever possible, we try to avoid general anesthesia by using either just local or regional, which means like a spinal anesthetic. There are medicines that anesthesiologists can use that reduce the risk of hypotension. Ketamine is one. And an anesthesiologist with experience with MSMDS will always have a pressor, a vasopressor, additional drugs ready to go that will increase blood pressure in case it goes down during anesthesia. So it's really, I think the most important thing is just to have an anesthesiologist who's familiar with MSMDS or has experience or has exposure and contact with the doctors here, like Patty and Mark, who have a lot of experience with MSMDS to get their advice. Because again, putting in a G-tube is really incredibly simple, and then it becomes more stressful when you realize that the patient is at risk for anesthetic complications. Not everything can be done under regional or local. Many things need general anesthesia, and that they just need to be done, but you just need an anesthesiologist who feels comfortable with that. That's all I have, and then it's ready for lunchtime. And I'm happy to talk over lunch.
I hope what's a really quick and simple question so when my daughter was 4 months old, we had her tested for malrotation and she did not have it. I was under the impression that she would be good for the rest of her life to not get malrotation. Is that not the case?
So that's correct. I'll answer your question first, and then another question that comes out of that. So if you get an upper GI, there's ultrasound and upper GI are the two ways to diagnose it. If you do not have malrotation, you will not have malrotation. Yeah, so those are pretty reliable tests. And if you, the other question that I wonder is, should everybody with MSMDS get tested for malrotation? There's no answer to that. For rare diseases, it's hard to get enough patients to know the risks and benefits. So I don't want to give a recommendation because there is, as far as I know, no published recommendation on that. But please tell me what you think.
We know of a total of 4 patients in literature, between the literature and the patients that we've been following that have had malrotations and surgeries for it. So it's not the most common presentation or phenotype, but it's usually early in life. In the first couple of years of life is when they present. Yeah,
because I will just, to complicate things, say that let's say you get, you say, oh, I'm really nervous. Let's find out if we have it. Okay, there's malrotation on the upper GI. That malrotation may never cause a problem. Many people have malrotation, never have an issue. But now we know about it. There's definitely going to be worry about it. Now you do have to subject the kid to general anesthesia to fix the malrotation. So there's a risk-benefit balance here that patient-specific, I think, is the only way to go.
My question was about sort of practically how we manage. I mean, my daughter takes calcium and magnesium to try to help with the motility, but she tends to alternate between diarrhea and constipation. Is there a way to tell whether or not there's an issue with a blockage versus just an ileitis versus some other dissection of a vessel? It's very hard to classify the discomfort in the abdomen rather than haul them into the emergency room all the time to try to. I'm just wondering about some of the classic signs between a blockage versus like ileitis versus some of the other things that we might run into.
Yeah, that's a great question. Maybe we can talk over lunch. I need a friend to talk to. The
GI people are great to talk to.
Well, the second talk, the second talk after lunch is Dr. Claire Zarkester. She's a GI motility specialist.
Yeah, we see her as well too.
Oh, okay, great. Yeah, it's very hard to diagnose. I mean, an obstruction imaging is the best way to tell if there's an obstruction, but there should be, if there's no prior surgery, the risk, or hernia, the risk of an obstruction, an actual blockage, is very low. And it's more likely a motility issue given the smooth muscle problem in MSMDS.
Some of the kids have had blockages and issues, so that's why we're.
Yeah, that's the problem. Some have had perforations of the intestine as well, which we think is due to ischemia, poor blood flow to a part of the bowel, but very rare, like really rare. Acta 2 is rare enough, but the perforation of the intestine is reportable. So, yeah, let's talk more. It's a great question, but it's a complicated one to answer.
Okay.
If all these contractile proteins cause malrotation, what's the data that you have to contract your gut to hold it correctly during development?
Oh, that is a great, this is more than a lunch conversation. I don't know the link between contractile proteins and rotation. Intestinal rotation is actually part of the way that the body knows its left from its right. It happens very early in development. It has to do with cilia that rotate in a certain direction. And so if you actually force the cilia to go in the opposite direction, the intestine will flip in the other direction. So but the cilia, like dynein proteins, these are not contractile proteins. And so I don't know what the link is. But why the gut rotates the way it does is a fascinating thing that's been studied for the last at least 30 years. And I just don't know why alpha-actin does that. But there are other people here who might.
Do gamma, the gamma actin, do they get malrotation?
I have to find out. I'm not aware of that. We see gamma actin, we think of pseudo obstruction, not malrotation, but it's a great question.
I had a very brief comment. Wow, thank you so much, Alan, for everything you've been doing for this community and the presentation. I learn always from sitting here. I do think there is a community, there is a group organizing, or there's several organizations for the gamma. I have heard they have reached out to us because, oh, you are trying to fix that issues too, and we basically have put it in contact with you as well. But I have heard about malrotations in gamma, at least one baby. You
read about it
two there,
too. Yeah.
yeah. So that's one point. And the other one is just an MSMDS, is the smooth muscle, so the motility is all the other stuff that is happening in other systems. And then the vasculature, we have seen the ischemia taking place. So the vessels that feed the gut can get occluded in patients. So, and it's not something that we necessarily think when we have an abdomen presentation in a child, because it's not common to have ischemia in the gut, but it's definitely been shown in pathology. And so I think it's when you're assessing the patient, you have to think through what parts of the disease could be causing the syndrome.
Yeah, agreed. It gets back to your question. I mean,
That's right.
it's like in sickle cell, we get these crises of abdominal pain, maybe caused by relative ischemia. Could the same thing be an explanation for abdominal pain in MSMDS? Maybe.
And the lymphatic system, maybe there's gut edema, who
Yeah,
knows what's up play.
so much to learn.
Yeah.
All right, thank you.